Hi, everyone. Welcome to our Thursday webinar series. I'm Lourdes, Director of Patient Services with the Cholangiocarcinoma Foundation. We're glad to have you here with us today. For anyone who is on the call, please make sure that if you have questions for our presenter that you enter them into the chat or the Q&A, and please make sure that your questions are presented in a general manner versus very specific to your case, because he cannot answer specific questions. Dr. Sun-Young Lee is a gastrointestinal medical oncologist at the University of Texas MD Anderson Cancer Center. He specializes in hepatobiliary cancers, including liver and bile duct cancers, and leads clinical and translational research focused on targeted therapies and immunotherapy in the area of liver and bile duct cancers. Thank you, Dr. Lee, for being here with us.
Oh, yeah, thank you so much. Can you hear me? I just wanted to make sure.
Yes, we can hear
Okay,
you.
perfect. Great. Yeah, thank you so much for this great opportunity. And I want to discuss, this is a Cholangiocarcinoma Foundation, um, webinar series. I really wanted to discuss my clinical trial, which is going to get activated very soon. But at the same time, I have enough time today, I can spend 30 to 45 minutes for my presentation. So I'm going to uh, um, discuss FGFR2 fusion and blood vessels in the tumor and everything in detail. And I'm one of the GI medical oncologists working at MD Anderson. Um, Briefly, as we all know, biliary tract cancer is gradually we see more and more patients having biliary tract cancer over the last 15 years. Um, biliary tract cancer is still considered a rare cancer because there are only like 10 to 12,000 cases a year in the entire United States. But now the incidence is gradually going up. And as we all know, there was the ABC-02 trial, the trial of gemcitabine, cisplatin, um, compared to gemcitabine alone, and the study was published in 2010. And then between 2010 and 2022, Gemcis was the only first-line chemotherapy. While it was not really evolving really quickly in the biliary tract cancer space, what was happening in other types of cancer, for example, in melanoma in 2014, immunotherapy medication nivolumab was first approved by the FDA. And then later, subsequently, in 2015, nivolumab was approved in kidney cancer, lung cancer, and other types of cancer. But nothing was really happening until 2022 in biliary tract cancer. Quickly, I know there are our patients here today, but and we are all experts in this area. But I wanted to briefly discuss what cholangiocarcinoma means. It is classified based on the anatomy. So there are actually four different types of biliary tract cancer. The first type, it is called the intrahepatic cholangiocarcinoma. We say intrahepatic means inside the liver, cholangiocarcinoma, bile duct cancer, inside the liver, bile duct cancer. When we look at the bile duct structure, it looks like a tree. That's why people say it is a bile duct tree. There's a main trunk of the bile duct outside the liver. When the bile duct, main trunk of the bile duct entering the liver tissue, it makes the left side system, right side system, and small branches of the bile duct. And uh, quite oftentimes we see cancer cells or tumor coming from these small branches of the bile duct. But these small branches of the bile duct are in the liver. That's why we see those tumors in the liver. But we don't call this cancer liver cancer. We call this cancer bile duct cancer because it is coming from the small branches of the bile duct. But the bile duct branches are in the liver. That's why it is called the bile duct cancer. And then a second type of cancer is called the perihilar cholangiocarcinoma or hilar cholangiocarcinoma. So the hilum, Hilum. So hilum is a medical term, an entrance to an organ. So hilar cholangiocarcinoma, That means the tumor is located at the entrance to the liver tissue. So on this picture on the left side, you see a light green color, and you see a Y character shape area, and it is a yellow-green color. We see those tumors there, and it is called the perihilar cholangiocarcinoma. Its nickname, Kleskin's tumor. And then you see the blue color is the main trunk of the bile duct. It's called the distal cholangiocarcinoma. And then obviously there's a gallbladder cancer, which is a part of biliary tract cancer. So yeah, people used to think that intrahepatic cholangiocarcinoma is only 10 to 20%, carcinoma 50 to 60%, distal cholangiocarcinoma 20%. But this is an Asian like a ratio. In the United States or in Europe, for Caucasian people or African Americans especially, we see more and more intrahepatic cholangiocarcinoma. We think it is more than 50 or 60% in the United States and also in Europe. Um, Once again, there are four different types of bile duct cancer, biliary tract cancer, intrahepatic cholangiocarcinoma, hilar cholangiocarcinoma, distal cholangiocarcinoma, and gallbladder cancer. So although they are all called cholangiocarcinoma, but they are slightly different. For example, we see these DNA alterations and mutations. So for patients in the United States or European people, European patients, we quite commonly see the mutations. I put that here blue color, IDH1 mutation, IDH2 mutation is about 20% cases. And the FGFR2 fusion rearrangement, sometimes we see FGFR3 or 4 amplifications, BAB1 mutation, and the CDK2A, 2B. They are quite well-known DNA mutations and alterations commonly found in the United States and Europe. But when we get patients in Asian countries, Chinese, Japan, and South Korea, although they are located in the liver, intrahepatic cholangiocarcinoma, they are slightly different. We quite often see TP53 mutations and KRAS mutations, SMAD4 mutations, quite common in Asian countries. That's probably because a lot of Asian people have hepatitis B. And hepatitis B can irritate the liver tissue or the bile duct tissue. As a consequence of chronic liver and the bile duct tissue damage, and it is altered and irritated, eventually transform into a tumor. And the extrahepatic cholangiocarcinoma, including gallbladder, hilar, and distal cholangiocarcinoma, we tend to see more KRAS mutations. We tend to see more TP53 mutations, which are closer to intrahepatic cholangiocarcinoma in Asian countries. So the reason that they are very important is because there are clinical trials coming based on these mutations and alterations. So very important to see patients' gender, patient's race, and where the patient is coming from. Is the patient coming from Asian countries or the United States or European countries? This is a mutational profile and alterations published in 2016. IHCCA means intrahepatic cholangiocarcinoma. EH means extrahepatic cholangiocarcinoma, gallbladder cancer. And it was found that, for example, ERBB2 amplification or HER2 amplification is found in 4% cases for intrahepatic cholangiocarcinoma, 11% in hilar cholangiocarcinoma, distal cholangiocarcinoma, more common for gallbladder cancer, 16%. Asian population, more than that. South Korean patients having gallbladder cancer, up to 40% cases are HER2 amplification. BRAF mutation, there are clinical trials going on. KRAS mutations, more common in extrahepatic cholangiocarcinoma. FGFR1 to 3 fusions and amplification, especially FGFR2 fusion, almost exclusively in patients having intrahepatic cholangiocarcinoma. IDH1 mutation, 15 to 20% cases. IDH2 mutations, 4% cases, almost exclusively in intrahepatic cholangiocarcinoma and ARID1A mutations. So between 2014 and 2025, going back to the same diagram here, In 2020, there is a medication called Pemigatinib, or brand name Pemizir. And there was a big clinical trial called the Fight 202 clinical trial. And they tested a medication Pemigatinib or Pemizir for patients having FGFR2 fusion and rearrangement. And medication was really great. I want to excellent. So the medication was approved in late 2020 for patients having FGFR2 fusion and rearrangement. In 2021, a similar medication called infigratinib was approved. It is not used anymore. It is off the market. 2021, ivosidenib or Tipsovo generic name, brand name was approved in 2021. Other medications, dabrafenib, tramatinib, targeting BRAF, V600E mutation, furibatinib, another FGFR inhibitor, published and approved by the FDA in 2022, and more medications coming targeting HER2. There are at least 4 available regimens for HER2 amplified biliary tract cancer. So we are evolving, but slowly. As we all know, TOPAZ-1 trial, gemcitabine, cisplatin was added with durvalumab, and it was better than gemcitabine and cisplatin. And response rate was better, and the patients did much better. Although there was a small added side effect profile, but it was beneficial. That's why gemcitabine, cisplatin, and durvalumab was approved by the FDA in late 2022. Similar regimen, gemcitabine, cisplatin plus pembrolizumab was also approved in 2023. We use Gemcis and Pembro or Keytruda, a brand name, quite often in clinic. And then going back to the same thing. So intrahepatic cholangiocarcinoma, iCCA, IDH1 mutation is found between 15 to 20% cases. FGFR2 fusion or activating mutations between 15% to 20% cases, ERBB2, and then other mutations. Extrahepatic disease, FGFR activating mutation is really uncommon, and FGFR2 fusion doesn't really exist in tumors outside the liver tissue. So this is our lab result at MD Anderson. And the FGFR altered cholangiocarcinoma, viral cancer, is intrahepatic cholangiocarcinoma. The tumors are really fibrotic. It's a medical term, which means the tumor contains many scar tissues in the tumor. So when we imagine a tumor, we feel like the tumor is full of cancer cells in the tumor only, but in reality, that's not the case. Especially FGFR altered cholangiocarcinoma tumor, when examined under the microscope by a pathologist, is full of scar tissues in there. So the tumor volume occupied by cancer cells only is probably less than 5% or maybe 2%. The other 95% of the tumor volume is all from scar tissues. It is it's a classical feature of FGFR altered cholangiocarcinoma. Another well-known mutation, IDH1 mutation, the same thing. IDH1 mutated tumor has extensive scar tissues, which means the tumors are not really shrinking on chemo or medications. And this signal, FGFR signal, is related to blood vessel creation in the tumor. It's called the angiogenesis. That means cancer cells can create more blood vessels in the tumor. Cancer cells can pull more oxygen, more blood, or nutrition, so they can grow faster. EMT is called the tumor getting a little slightly more aggressive. And then also, like I mentioned, FGFR altered tumor has extensive scar tissues in the tumor, which means the tumor doesn't contain a lot of good immune cells fighting cancer. So it is kind of immunosuppressed. And then, there are medications that I briefly discussed: Pemigatinib, furibatinib, Licobi, and the Pemizir. And they are really good. And I'm going to go over the data and the cases in detail today. But on many patients, initially they get benefit, but later progress. So there is a unmet need to improve efficacy although the medication is exciting and really promising. So that's why I wanted to discuss the clinical trial with you today. So for example, this is another image from our lab. And then you see the left upper side is the image. Is a cholangiocarcinoma. And these pinkish color tissue, this is all like scar tissues that they look very pinky. And then when a patient received a Pemigatinib, the tumor became less fibrotic. And there are more immune cells invading and infiltrating the tumor, killing cancer cells. So we feel like FGFR inhibition by Pemigatinib or Leqvio can potentially activate the tumor's immune system, so it can pull more good immune cells contained in the tumor's immune cells can fight these cancer cells. The left lower figure, as I said, the graph is the immune system activation. Pre-FGFR inhibition, the tumor is quite immunosuppressed. But when tumors are exposed to FGFR inhibitors like Pemigatinib, Infigratinib, or Futibatinib, then the tumors get very immune cell fooling, they're filled in there. But while the tumor is getting smaller and smaller to chemotherapy, post-chemo, so here green color, the immune system is not really activated, even post-chemotherapy. It is quite different than the tumors are exposed to FGFR inhibitors. So FGFR inhibition with Pemigatinib or Futibatinib may be immunogenic. That means it can activate the immune system in the tumor. And then, as we all know, VEGF, vascular endothelial growth factor, it is a molecule expressed by cancer cells, for cholangiocarcinoma cancer cells. They are quite highly expressed in cholangiocarcinoma. I'm going to discuss that later in detail. And FGFR pathway is also playing an important role in blood vessel creation in the tumor. So basically, cancer cells are messing up the blood vessel structure in the tumor. They create extra blood vessels in the tumor. So it can impact medication invasion, circulation, reaching and killing cancer cells in the tumor. And the FGFR signal and the VEGF signal, they are kind of correlated from the lab. And that's why we want to attack cholangiocarcinoma with both an FGFR inhibitor and VEGF inhibitor at the same time. There has a potential synergic anti-tumor activity when they're combined together. Right side upper graph, this is a tumor assessment in the lab. Before the exposure to any medications, the tumor is big, the left side graph. When the tumor is exposed to lenvatinib, which is targeting blood vessels in the tumor, plus immunotherapy, anti-PD-1, the tumor shrank very nicely. And the sorafenib is another anti-VEGF. Combined with PD-1 immunotherapy, the tumor shrank. BGJ 389, it is the medication's name Infigratinib, a similar medication to Pemigatinib or Leqvio. When it was combined with immunotherapy, the tumor shrank more. Now, there is a potential synergy when the cholangiocarcinoma cancer cells are exposed to immunotherapy combined with medications targeting blood vessels. So from all this, we want to look at the synergy from the combination of Pemigatinib targeting FGFR and Bevacizumab targeting blood vessels in the tumor, and the Atezolizumab immunotherapy and activating the immune system. This is I want to discuss these medications one by one. So Pemigatinib or Pemigatinib, it is targeting FGFR pathway, and the activity is really good and quite promising. And it is selectively targeting molecules called the FGFR1, 2, and 3. And this is a response curve and published in 2020. And the response rate was 37%. The response rate is a medical term. So out of 100 patients receiving the same medication, how many patients are getting the tumor shrinkage by more than 30% of tumor volume? Then it is called a response. Stable disease, the tumor may be shrinking slightly, or the tumors are not really shrinking, but not really growing. And it is called a stable disease. So response plus a stable disease is called the disease control rate. And the median progression-free survival, that means time taking from the initiation of a certain medication to progression is a medical term. So response rate was 37% to Pemigatinib. Disease control rate was 82%, which is a combination of response, tumor getting smaller, and the stable disease, tumor not getting smaller but not really growing. And then on average, 7 months later, patients started showing progression. This is a real-world data, and one study from Italy and France, and another study from the US. And you see all RRs, response rate, objective response rate in real data is a 45% in Europe. It is a 59% in the United States. It was like it was a 37%. And the CR means complete response, the tumor disappearing. PR means partial response, the tumor is getting smaller. The chance of getting partial response was 43% in Italy and France. It was 54% in the United States. SD, SSSM, DS and Dev, SD, a stable disease, about 39% in Europe and 27% in the United States. So disease control rate, CR plus PR plus SD was 84% in Europe and 86% in the United States. And the median progression survival was 8.7 months in Europe and 7.4 months in the United States. And then the previous study published in 2020, response rate 37%, disease control rate is 82%, the median PFS 7 months. So in real, world data and also in clinic, for example, in my clinic, patients then tend to get better shrinkage of cancer than 37%. So that's why real world data, it is 43% and 54%. So this is one of my patients, patient number one. Is a 67-year-old gentleman, intrahepatic cholangiocarcinoma, diagnosed in October 2020. And the patient received gemcitabine and cisplatin from November 2020. The patient came to my clinic for a second opinion in February 2021. And then we got a scan in February, and the CT scan already showed progression from gemcitabine and cisplatin. So it is now like how many months? Like in November, December, January, and February. So 4 months later, the tumor was already growing. And the patient had multiple teeny tiny nodules in the lung and multiple lymph nodes in the abdomen. And as you see here on the CT scan image, there are like huge tumors in the liver. So he came to my clinic, and then I referred the patient to radiation oncology colleagues here at MD Anderson. And the patient received a proton therapy. And then also right after that, we started Pemigatinib, so Pemizir, 13.5 milligrams, starting in March, right after completing radiation. It was 2021, like 4 years ago. Patient had complete response, and all the tumors are gone. And then, the tumors in the liver received radiation, so he had an excellent response to proton therapy. And then also, in addition to great response to radiation, it was impossible to cover everything in the liver because the tumors are so big. But these tumors all disappeared, and the lung lesions all disappeared, and lymph nodes all disappeared. And patient developed some ascites from portal hypertension. The abdominal pressure was getting elevated. And then he was found to have a obstruction in the hepatic vein. So you may see here is a red color here. It is a stent placed in the hepatic vein, and then the ascites disappeared. And he is still alive, and he has no tumor in the body. All the tumors disappeared in the lungs and abdomen. So I've been following the patient every 6 months in my clinic. Patient number two. 55, and the patient has intrahepatic cholangiocarcinoma, first diagnosed in January 2024. Patient received gemcitabine, cisplatin, durvalumab for 4 months, and the patient progressed. And then patient has also abdominal lymph nodes, and the patient started Pemigatinib, 13.5 milligrams in June of 2024. But 4 months later, patient had a progression. The previous patient, like no cancer over 4 years, close to 5 years. Now this patient progressed on Pemigatinib, the same medication. 4 months later, patient is progressing. Number three, another patient, a 60-year-old female, intrahepatic cholangiocarcinoma, April 2024, large tumor as you see here. You see the bright tumor on the right side of the liver. And then the abdominal lymph nodes, deeper lymph nodes called the aortocaval lymph node. Patient received a neoadjuvant Pemigatinib over 6 months, and the patient had excellent response. And patient ended up having right hepatectomy and then also lymph nodes removal. And then the patient received adjuvant Pemigatinib over 6 months after the surgery is done. And currently the patient has no evidence of cancer. So I'm going back to these images later. The Pemigatinib is very well tolerated. Most patients tolerate the maximum dose of 13.5 milligrams quite nicely. I have a few patients taking 9 milligrams because of the nail toxicity and then the hair and then some eye issues. Almost all the patients develop hyperphosphatemia. That means elevated phosphorus level, because Pemigatinib also attacks FGFR1 related to the phosphorus balance maintenance in the body. That's why almost all the patients develop elevated phosphorus level. But we start phosphate binders like with the sevelamer, 800 milligrams 3 times a day, and then we increase and decrease this medication. I've seen 2 cases of my patients where phosphorus level was not really controlled. So the phosphorus are bound to calciums in the body, developing calcium phosphorus crystals in the skin, getting us teeny tiny skin nodules. But they all disappeared after we controlled the phosphorus level better. Eye side effects are well known, but it is quite rare. Sometimes it can cause a blurry vision, but it is quite rare. But the surface side effect, the hair getting thin, and then the skin getting brittle and dry, and the nail toxicity is very common. Many patients get the nail thickening, and then later a few patients, sometimes patients lose like a nail. The nail is just gone and then getting thick and then brittle. And then also the hand-foot syndrome, the skin in hands and feet can get irritated. It's not really common. GI side effects like a diarrhea is, I want to say, rather rare. But there are other medications, including Bevacizumab or Leqvio. And if you do the second line, the patient might have received Pemigatinib first, and then there was some progression. We do a second line Bevacizumab or Leqvio. Patients tend to get more side effects. Now, this is my data. It was presented a couple of weeks ago at GI ASCO in San Francisco. And we analyzed 130 patients treated at MD Anderson with Pemigatinib, Bevacizumab, targeting FGFR. And then one thing we found was, there was my feeling in clinic. So when I reviewed my patient scan, when the tumors are really like dark on the CT scan, for example, you see the CT on the right upper side, the tumor in the center of the liver looks quite dark. It is darker than the liver tissue, as you can see here. But the right lower side, another patient, the tumor is brighter than the liver tissue. For some reason, I noticed that these patients do better having a brighter tumor. So we analyzed the tumor brightness. Is there any difference in terms of response rate and the duration of response to Pemigatinib or Leqvio for patients having the same FGFR2 fusion? We found that brighter tumors respond much better than patients having a dark tumor. So obviously, today's conversation is about a combination of this FGFR inhibitor plus a medication targeting blood vessels. So my analysis shows that there's something going on. It's a combination of FGFR and also tumor vascularity, blood vessel. And based on the patient's tumor brightness, we grouped the patients into three groups. And patients having the brightest tumors on CT or MRIs had the best response. Then compared to patients having a dark tumor. So when I treat my patients in clinic, I always look at the tumor color, and I can get an idea about how long my patient is going to benefit and maintain the response. This is an anti-VEGF, the Pemigatinib or Dicobi, Pemigatinib, Futibatinib medications targeting FGFR. What about medications targeting blood vessels in cholangiocarcinoma? There's a small trial called the LEAP-5 clinical trial. And there was a study of lenvatinib targeting FGFR, blood vessels in the tumor, plus Keytruda or pembrolizumab. And it is a small study, and the response rate was 25%. And the stable disease over like a 53%, and the median progression-free survival over 5 months. And because based on this LEAP-5 clinical trial, the NCCN guideline did recommend lenvatinib plus pembrolizumab. And then unfortunately, it was recently removed from the NCCN guideline. Personally, I'm a big fan of lenvatinib. Personally, other oncologists may not agree with me. But I've treated more than 30 patients in my clinic with lenvatinib. And then I've seen very good responses, which I'm going to share now. But unfortunately, it was taken off the NCCN guideline. And then the reason that it was taken off was because the evidence wasn't really strong enough. And then I don't know, it was removed. So I'm not really able to use this medication anymore in my clinic. See, this is an MD Anderson study. And we treated about 30 patients, and lenvatinib plus Keytruda, and the median progression-free survival was about 6 months. And I have a couple of patients taking this medication over three years. I don't think we have a lot of medications treating cholangiocarcinoma with a duration of response more than 3 years, right? So I have a few patients having great response over like 3 years. Only 5 patients received lenvatinib in the second-line setting, which means after gemcitabine, cisplatin, plus minus pembrolizumab or durvalumab. And all other patients received lenvatinib 3+ lines. And the lenvatinib is honestly not an easy medication to handle, but some patients didn't handle this medication very well. But the duration of response was about, on average, 6 months. This is a survival curve. The response rate, once again, the response rate, out of 100 patients, how many patients get the tumor shrinkage? It was about 30%. And as you see here, these are well-known mutations: IDH1 mutation, KRAS mutations, TP53 mutations, and ARID1A mutations. So quite common mutations. For some reason, patients having IDH1 mutation and ARID1A mutation here, ARID1A mutation gold color, and the IDH1 mutation, the brick color, like red color, they had a better response. When a patient had TP53 mutations, they didn't have great response. These blue circles are located on the left side of the curve, right, as you see here. So these patients don't get a good response. So TP53 mutations are related to decreased response to lenvatinib, and IDH1 mutation and ARID1A mutations are related to bright tumors on the skin, and they had better response to this regimen. And the reason the medications that we want to combine with Pemigatinib is Atezolizumab plus Bevacizumab is well-known medications for GI cancer. For example, this is the data from hepatocellular carcinoma, liver cancer. And Atezolizumab plus Bevacizumab were very active and still very active. Especially Bevacizumab is the medication targeting blood vessels in the tumor. And compared to another medication, sorafenib, the medication was exciting. So the medication is now approved by the FDA for liver cancer. But the medication is not approved for cholangiocarcinoma. And the bevacizumab, the medication targeting blood vessels, because it is modulating blood vessels and it is given through the IV circulating in the body. So it can cause blood vessel related side effects. So it can increase patient's blood pressure, number one side effect, because it is modulating blood vessels in the body. So it can increase the risk of bleeding. It can also increase the risk of blood clot. It can also damage the kidney. But because we use the medication quite often in clinics, when these side effects happen, we know how to address these side effects. The clinical trial that I want to discuss today is a trial of Pemigatinib combined with Atezolizumab and Bevacizumab for cholangiocarcinoma with FGFR2 fusion or rearrangement. It has two parts. The first part, we want to make sure it is safe. So there is a small safety run-in. We are going to treat between 3 to 6 patients having FGFR2 fusion. And then we are going to start from 13.5 milligrams combined with Atezolizumab plus Bevacizumab. And if our patients are handling the medication very well, then we are going to proceed with phase 2 with a medication dose decided at the safety run-in phase. So 13.5 milligrams, so this is a starting dose. If a patient has some side effects from Pemigatinib combined with the other two medications, we are going to go down to 9 milligrams. Either 13.5 milligrams or 9 milligrams, we are going to proceed with phase 2 later based on safety. And then obviously patients having intrahepatic cholangiocarcinoma, having FGFR2 fusion or rearrangement, who have progressed on gemcitabine-based chemotherapy. The primary endpoint is safety. And we are not going to look at the safety only. We are going to look at the response and everything. So objective response rate, disease control rate, duration of response, and progression-free survival. And then another very important thing is we got to learn why the medication is going to work. We got to learn why medication is not going to work. So once we get a tumor, we are going to analyze a tumor tissue with our advanced technology. And key inclusion criteria, as we all know, we want to help every single patient. But each clinical trial has a I want to say strict inclusion and exclusion criteria because we are not really sure about the safety, and we want to make sure. So patients who received gemcitabine-based chemotherapy and having FGFR2 fusion and rearrangement, they'll be eligible for the trial. But if a patient has received FGFR inhibitors already, Licobi, Furibatinib, or Pemigatinib, Pemigatinib, or other medications, or Bevacizumab, medications targeting blood vessels in the tumor, the patients are not eligible for the trial. And then we are going to get the tumor biopsy. If a patient already had a tumor biopsy in the past, we can potentially skip it. But at week 9, we want to get another tumor tissue if a patient is happy to go through another biopsy. So that way we want to analyze it and we want to study the evolution of the tumor or evolution of tumor mutations. So we want to analyze the tumor microenvironment. And we are getting support from the Insight, the pharmaceutical company manufacturing Pemigatinib. And they are going to provide the clinical cost and the research funding and everything. And they are funded by Insight. And Atezolizumab plus Bevacizumab are not FDA approved, not recommended by the NCCN guideline for cholangiocarcinoma. But we are going to receive the medication directly from Genentech. And this is a PI or like a doctor like myself initiated clinical trial. So I wrote the entire protocol, and then also the trial is not yet open as of today, but we are working on finalizing a contract with Genentech. The trial is expected to be activated in the next 1 month, hopefully 1 to 2 months or so. All right, so this is the end of my presentation. So I'm happy to answer any question related to the presentation that I made today or any question about cholangiocarcinoma. Thank you.
Thank you, Dr. Lee. That was great. We have a few questions that have come in. If anyone has questions, please put them in the Q&A or the chat for us. Why did you use Pemigatinib and not Futibatinib?
Yeah, so the main thing is this is a technical issue. So the trial, the medication that we initially selected was Infigratinib. It was like 2021. And then we got the support from Infigratinib, the company. But as we all know, Infigratinib, the company decided to discontinue the medication from the market. And we are not able to continue the medication. And then in 2022, Pemigatinib was approved by the FDA. So we contacted Insight, and then we got the approval from there. In the later, the Futibatinib was also approved by the FDA. So that's the reason that we chose Pemigatinib, not the Futibatinib.
Okay. Is there any correlation with BAP1 co-mutations with FGFR2 and the response to treatment?
No, not actually. So it's a great question. BAP1 mutation is a well-known mutation, quite commonly found in cholangiocarcinoma. BAP1 mutation the data are not really mature, but a BAP1 mutation is known to be related to little more aggressive tumor biology than patients having no BAP1 mutation. But in terms of response rate to Pemizir or Leqvio, I don't think there is any difference.
Okay. Can you clarify the reason tumors are bright or dark? Is it because of the high level of blood vessel involvement?
That's correct. A great question. When you get a CT or MRI each time, like every 2 to 3 months, the radiology pushes the IV contrast. When the tumors contain more blood vessels in the tumor, the blood vessels in the tumor can absorb IV contrast quickly. So that's why the tumors look bright on CT or MRI. That means when the tumors look brighter on CT, that means the tumors contain more blood vessels. And also personally, I analyze our patients treated at MD Anderson with a CT imaging brightness, and the tumor gene expression profile called the messenger RNA expression level related to blood vessel creation. There is a direct proportional correlation between the tumor brightness and expression of genes, messenger RNA genes related to blood vessels called the VEGF-A, VEGF-B, VEGF receptor 1, 2, and 3.
Okay. Is the patient excluded from the trial if they had durvalumab in the past with GemCis?
No, not at all. I mean, like every single patient, since 2022, durvalumab infancy approval, every single patient receives durvalumab or Keytruda pembrolizumab. No, so when the reason that we wanted to add Atezolizumab, another immunotherapy combined with Pemigatinib is, as I showed you today during my presentation, when chemotherapy is received by tumors, chemotherapy doesn't really increase immune system activation in the tumor. But when cancer cells see and are exposed to FGFR inhibitors like Pemigatinib or Futibatinib, tumors get more activated in terms of immune system activation. And then now we add a brand new immunotherapy. So although patients might have received immunotherapy in the past, when we add a brand new immunotherapy, there's a good chance of getting benefit from a new immunotherapy medication. So patient won't be excluded from the trial, even though they have received Imfinzi or Keytruda in the past.
Okay. What about someone who is currently on Pemigatinib? Are they ineligible?
Yeah, so the patient is not a candidate for the trial. But as you know, there is a Futibatinib if there is any like a progression of cancer. Although in reality, Pemizir and Leqvio Futibatinib, they are almost the same medications. But we have Futibatinib, and then now there are international trial. There's an international trial going on with a medication called the Tinangotinib. for patients who received Pemigatinib or Wegovy in the past, the cancer progressed. Now we do a brand new medication called Cholangiocarcinoma, which is also active at MD Anderson. And then I discussed another medication called Lenvatinib today during my presentation. And Lenvima has a very good efficacy, although unfortunately, because of the NCCN's unfortunate decision, we are not able to get the medication very easily in clinic, which is really, once again, unfortunate. But Lenvatinib has a very good efficacy for those patients. Lenvatinib is similar to Cholangiocarcinoma running on the trial. So Lenvima may be a good option for patients like you.
Okay, and this is only for FGFR2, correct? If someone has
That's correct.
FGFR1, they would not be eligible.
FGFR, that's correct. So only two. But it all depends. There are different types of DNA alterations. The fusion or rearrangement is slightly different than mutations. Patients having FGFR2 fusion can respond to Pemigatinib or Wegovy quite well, but there is an activating FGFR2 mutation, not the fusion, but mutation, or FGFR3 amplifications, or FGFR4 amplifications, or one amplifications or mutations. When they are activating, they are similar. I do think they are going to get benefit from Wegovy or Pemigatinib. So what I usually do in my clinic is, because FGFR2 fusion and rearrangement is the indication for Pemigatinib or Wegovy, when I write a note, I mention FGFR. And then when we go through the insurance will see that, right? So insurance is a big problem here. But when they see FGFR or as I say, FGFR2, I don't specify fusion or rearrangement. Then almost all the insurance companies do approve Bevacizumab or Pemigatinib. So I think we can definitely do that in this way. Or another good medication, Lenvatinib, is a very good medication for those patients.
Okay. Are international patients included in your trial?
I think so. The medications, Pemigatinib, would be provided by Incyte, and the Atezolizumab plus Bevacizumab, they'll be provided by Genentech. But there's an issue. We just don't provide the medications. We have to have blood work. We have to have a scan, and then those costs are not coming from the sponsors, because they are like very expensive. They are part of standard of care. And in reality, if a patient has no American insurance, it'll be quite challenging, to be honest.
Okay. If someone has prostate cancer in addition to cholangiocarcinoma, does that impact the potential participation in the trial?
I don't think so. I mean, usually we say prostate cancer, another cancer is a contraindication to any clinical trials, but it all depends. Is prostate cancer really active? Or the patient prostate cancer is indolent and not really active. I think we can get those patients.
Okay. What about patients that have PSC?
Oh,
Are they
PSC.
eligible?
Yeah. Yes. So I'm actually presenting another webinar next month in March about PSC and cholangiocarcinoma. For PSC, FGFR2 fusion is extremely rare. So I'm going to share my data next month. But I do have a few patients having FGFR2 activating mutation, not the fusion. I have one patient having PSC and FGFR2 fusion. And there's no reason not to get this clinical trial, not to get immunotherapy. I'm going to share the data next month. But PSC is one of the autoimmune disease, and there is always a concern about immunotherapy activating the immune system. Then I have autoimmune disease like PSC or ulcerative colitis or Crohn's disease. Am I going to get immune system flare, making my PSC or autoimmune disease or UC or Crohn's worsening? No, that's not true. We have treated about close to 20 patients having PSC, UC, and Crohn's disease. And only one patient had some diarrhea from immunotherapy. The other 19 patients did very well. I get second opinion, third opinion in my clinic for those patients quite often. My oncologist didn't prescribe immunotherapy because I have PSC, but I always talk to them. Patients getting PSC, autoimmune disease, receiving immunotherapy have actually better response. So in this case, PSC, going back to your question, PSC is not a contraindication to getting this clinical trial.
Okay. How does someone get signed up for the study?
Yeah, so you can send me an email or send my team an email. Then we can start screening the patient. And at the same, as of right now, as of today, the trial is not really not yet activated. We are still going through some contract issue with Genentech. But hopefully we can get the trial activated in the next like 1 month.
Okay. Does the patient have to be a certain cancer stage to be a candidate for trial selection?
No, so the cancer staging is not really important here. The main thing is the patient is not a candidate for like surgery. The surgery means we go there and then remove the tumor by surgery. But when the cancer is beyond the surgery, then the patient will be eligible for the clinical trial.
Okay. Well, it does not sound common. Were there any extrahepatic bile duct cancer cases with FGFR2, and would these cases be eligible for the trial?
It's a great question. I can talk about that another next hour, but FGFR2 fusion and FGFR2 rearrangement is almost exclusive in intrahepatic cholangiocarcinoma. But I have seen patients having FGFR2 mutations, which is activating mutation, which means the mutation, although it is not fusion or rearrangement, is behaving in the same fashion as FGFR2 fusion. But when those patients had activating FGFR2 mutation in the gallbladder cancer or cholangiocarcinoma or distal cholangiocarcinoma, I used to do Pemigatinib and Bevacizumab because it is FDA-approved medication for cholangiocarcinoma, not just intrahepatic cholangiocarcinoma. And I mentioned FGFR2. I omitted fusion there, and then I got the medication. There's no response. So I see those patients in clinic. What I do is I just don't do this medication alone. I combined Pemigatinib or Bevacizumab, the Gobi, with chemotherapy, the FOLFOX or Gemcis or FOLFIRI. And without chemotherapy, they don't get a lot of great response.
Okay. I think you already said this. Someone who's on Gemcis and Durva can enter the trial, but what about somebody who is on FOLFIRINOX?
Yeah, I mean, it's a FOLFIRINOX is given after progression on gemcitabine cisplatin, or the patient's getting FOLFIRINOX for the first time. All depends. I think we can potentially get the patient.
Okay. What is the sensitivity of the ctDNA to identify changes in the circulating tumor cells that may indicate response rates? Do you just look at the numbers, or do you look at what the cells express?
Yeah, so ctDNA is a big topic in cholangiocarcinoma, also primarily colorectal cancer. And there's a lab called the Signatera. I say a lot of people do like a Signatera once every 3 months or so, and then quite often times I also use that. And the Signatera has a few issues here. The first issue is it accurate? Sometimes it is not accurate. I've seen patients getting a Signatera number like after surgery, slowly going up. It was a 0, and then like 3 months later, it was like a 0.1. And then we got concerned. We get a CT and an MRI, as a PET scan, and all the scans and a bunch of things, and then nothing. And then 3 months later, we decided to just follow, and then Signatera came back 0 again. But this is the test is not really perfect, and it can cause a lot of anxiety. And although we do that quite often times in clinic, in reality, but if it comes back positive, we don't know what to do. If it comes back positive, it just causes anxiety, and it happens all the time in colon cancer. If it comes back positive, are we going to treat this number? Are we going to start any chemo? Um, if we agree to do something, then what chemo, what medication we want to do, for how long? And then when the cancer cells are exposed to drugs and drugs and drugs, they can get resistant to certain drugs. Is it going to make the cancer more aggressive? So we have no answer to these questions. So when before I order ctDNA, I always have an extensive conversation, frank conversation with my patient. But ctDNA, I mean, when a patient is on a certain medication like a trial or gemcitabine, durva, FOLFOX, or any medication, we follow the ctDNA number. Although it is causing anxiety, sometimes we can get an idea about whether the cancer is responding, not responding, because we see a trend. Yeah, and but in clinic, yeah, it is a role, but in reality, we don't know what to do.
Is this line of care only available on the trial?
Yeah, yes, it is only available at MD Anderson. This is a single study, a single center study, and it is not going on anywhere else. Yeah, yeah, and only at MD Anderson.
Okay. Can the initial biopsy identify other markers that will identify response rates to targeted therapy?
The question is not just FGFR2, but other
I
mutations?
think in general, yes,
Yeah,
perhaps.
yeah, yeah, sure. I mean, yeah, in terms of biopsy, like so we get the biopsy quite often because like a cancer can change, and then there's a tumor mass, and then we stick in a very thin needle, and we only get a tissue from a small portion of the large tumor. And quite often times we miss a very important mutation. So I always get and recommend the biopsy, more and more biopsy. As we get more tissues, there's a better chance of identifying mutations that are not really, captured. We quite often times do circulating tumor DNA from Foundation Medicine, MDNS, and internal platform, or carries, the Guardant, that there are many different types. So we do that all the time. So we can, as we get more and more test, there's a better chance of capturing mutations. And based on the patients, where we are in terms of cancer, is the cancer responding or not responding to gemcitabine and durva, gemcitabine and pembro? Where are we? And based on that, we make a decision about when and how we want to use the medication. For example, we have a limited time today, but say the tumor testing comes back with HER2 amplification. So HER2 amplification is about 45% in intrahepatic cholangiocarcinoma, very common in gallbladder cancer. While the patient is getting gemcitabine and durva, ctDNA or tumor testing comes back with HER2 amplification, that we tend to add HER2 targeted medication to gemcitabine and durva. We don't switch, but add. And we can make a lot of decision and a lot of different things based on the mutational profile and cancer. So every patient is different.
Okay. Can a patient enter the study at MD Anderson in New Jersey?
Uh, no, yeah. So, but I'm very sorry. Yeah, I'm very sorry. But yeah, no, I'm sorry.
No, that's okay. Can you share your thoughts on the correlation of TP53 and FGFR2 fusion resistant marker?
Yeah, great question. The answer is there probably is a correlation. Probably. We haven't quantified that yet. But TP53 mutation isn't really common in intrahepatic cholangiocarcinoma. It is quite common in extrahepatic cholangiocarcinoma. Um, TP53 mutation is related to a little more aggressive tumor biology, and it is related to cancer not really responding to gemcitabine and durva or immunotherapy, and also targeted therapy options. So I think overall, my sense is when there's this mutation, the cancer is a little trickier than treat, including co-alteration, including FGFR2 fusion.
Okay. One last question. You mentioned that bright tumors have more blood vessels when a VEGFR inhibitor drug is given. Does it inhibit increasing the number of blood vessels or normalize abnormal blood vessels?
That's correct. They're going to destroy blood vessels in the tumor. That means cancer cells are not going to get nutrition, oxygen, and blood. So then that's why the tumor cells are killed by the medication. So for example, I showed you the lenvatinib data, and I quite often see the response to lenvatinib when tumors are brighter. And then I see a dramatic response. Sometimes blood vessels are all like destroyed, especially when we look at the tumor on CT or MRI. Tumor edge is more active because they are expanding. The tumor edge contains more blood vessels. When these medications, bevacizumab or lenvatinib, is added, they can kill those blood vessels and shrink the tumor. So brighter tumor tend to respond slightly better. But it doesn't mean that dark tumors don't contain blood vessels in there. So that's why we want to add bevacizumab on this clinical trial.
Okay. Thank you so very much. I want to be respectful of your time. We appreciate you sharing about this clinical trial, and I'm sure that we can put the link with this webinar once it's active so patients can know where to go to get more information for it.
All right, great. Thank you so much for your time. And I'm happy to answer any other questions. And we can talk about this all day. Yes.
Thank you, Dr. Lee. I hope everyone has a good rest of your day.
Thank you.